And the next introduction, I better not screw up introducing my boss. Dr. Diane Miller, I think, is well known to most of you. She is the Chu-Wei Chair in Gynecologic Oncology, an associate professor in the Department of Obstetrics and Gynecology at UBC. She's also the provincial tumor group leader for gynecology at the provincial level. I'm always impressed. Diane was awarded the Terry Fox Medal for her role in cancer control in 2012 and has also been the recipient of the Gynecologic Oncologist of Canada Presidential Medal. So, boss?
It's great that Dr. Stewart occasionally remembers that I am his boss. I get to finish up this session with the aspirational talk, hopefully. And what I'm going to talk about is where we go with OVCARE, but it's a little bit more than OVCARE. I think David talked to you about OVCARE was born on the back of a napkin and was very aspirational when we started it, and I think the successes that David and the research team have brought have far exceeded what we expected. But you've also heard from Gina, and British Columbia has a long history of leadership in cervical cancer screening particularly. I'm very touched by the fact that Dr. David Boyes recently passed away at the age of 94, and for probably many people in this room have never heard of Dr. Boyes, but Dr. Boyes basically started pap smear screening worldwide. British Columbia had the first ever pap smear screening population-based program, and it took 20 years, but Dr. Boyes and his team at BC Cancer were able to demonstrate that cervical screening worked. And literally, over the years since 1970, there have been hundreds of thousands of lives that have been saved from a project that started in BC. So I think it's fair to be aspirational when we talk about gynecological cancers. So we felt that we have now a lot of strength in cancers of the upper genital tract, endometrium and ovary, and we've always had strength in the lower genital tract cancers. Gina's talked a lot about cervix, but cervix isn't the only HPV-related cancer that we see in women. We see cancers of the vulva and cancers of the anal canal, both of which are the majority of time related to HPV. So we're going to see some of the benefits of vaccination actually accrue to those groups as well. So what we're looking at now is developing a women's reproductive cancer network. And I think that's the future of OVCARE. OVCARE is just going to be part of a consortium where we work with Gina and her team, and Lori and her survival team, and Deb and her infectious disease team. I think you've heard that some of these cancers are infectious. So what we're going to do is we're going to turn the page on the burden of women's reproductive cancers. We know that every woman is at risk for developing a cancer of the reproductive system. And in 2016, of the 100,000-ish cancers that occur in women across Canada, about 12% of them will be gynecological. And we feel that we have a significant chance of decreasing both the incidence and the mortality and the suffering from gynecological cancers. Many of these are preventable. David talked about it a little bit. The three big gynecological cancers that we deal with are uterine, ovarian, and cervix. Uterine cancers, the majority of them are actually lifestyle cancers. They're heavily related to metabolic syndrome, obesity, hormonal intrinsic and extrinsic influences, and we have great insight into how we can prevent these cancers. We're not doing a very good job of it, but as I said, I get to be aspirational, and I think there are many things we can do. Ovarian cancer, David's already talked to you about our prevention program. I think we're starting to see the benefits. I think we judging from the fact that it took Dr. Boyce 20 years to demonstrate that pap smears would decrease the incidence and mortality of cervical cancer, I think it's not surprising that we estimate it's going to take 20 years before we start to see the incidence of cancer dropping. Hopefully we'll see the incidence dropping in women who have had self-injectomies prior to the 20 years. We're very hopeful. With regard to cervical cancer, Gina's already mentioned the Hpv vaccine. I think my personal opinion is in this province we have to put a lot more effort into increasing the rate of Hpv vaccines, because that's really the key to preventing almost 90% of cervix cancers, 50% of vulvar cancers, and 70% of cancers of the anal canal, none of which are a pleasant experience to go through. I'm not going to go through this in detail because I'm conscious of the clock, and everybody else got 12, and apparently I only get 7 minutes, David, they told me. I guess it doesn't help being the boss, does it? So we do actually have programs, as I said, we have a lot of clues as to prevention. We've worked in the therapeutic realm, and we've worked in prediction. We have a great new program in uterine cancer, which will tell us which of the cancers actually require additional treatment and which ones do not require additional treatment. You know, I'm in the business of doing surgery. We give chemotherapy, and we provide radiation to our patients. And I think what we really need to do is personalize it and refine who needs treatment and who doesn't, because there's toxicity associated with all our treatments. So putting everybody into one bucket and treating them all the same when a large proportion of them don't need treatment is not actually a victory. And then we have to look at women living with cancer. I see women who are living with cancer or who have survived cancer in my life many, many times, and there are many issues related to that, psychological, social, sexual, and many of which we have not in the past dealt with very well. And I really think that Laurie's work and interactions with our patients are going to take us forward on that. We want to put this all together. So what we're doing right now is we've got little buckets of things that we can do, but what we want to do is we want to develop and validate basically a toolbox for women as they go through their life journey that we are to help them prevent gynecological cancer, and if they do get gynecological cancer, hopefully to do those things that minimize the effects of treatment, treat the people that need to be treated, prevent the cancers that can be treated or can be prevented, and move forward in that regard. I'm not going to go through that one. It's kind of the same. So I love this slide, and I thank Michelle Wu for providing me with this. But basically, as we go through our journey of life from crawling to our senior years, we know that we can make interventions at various times that will have a huge impact on our future health. Gina's already mentioned the Hpv vaccine, which is a vaccine that we give to teens. The cervical screening, cervical cancers occur the youngest of the cancers that we see. The ovarian cancers, we now know that there are a number of epidemiological factors we need to pay attention to. David's talked about the two big classifications of epithelial ovarian cancers, the fallopian tube, high-grade serous cancers, which are the most deadly, and then the second and third most common types of what we formerly called ovarian cancer, which develop in endometriosis. And we're just at the cusp of learning what to do about these atypical areas of endometriosis, whether these cancers can be prevented or whether we can take advantage of some of the mutations for targeted and less toxic treatments. And then, of course, lifestyle goes through the continuum of a woman's life, and I think some of the things that we do know about the development of endometrial cancer we need to be taking advantage of throughout the woman's lifetime. He's kind of looking at me. Whoops, what happened here? Oh, I think that was my last slide. So that's what it was. So basically, as I said, I get to be the aspirational person, and we have developed a collaboration with Laurie and Gina and Gavin and David, and we are looking towards developing this gynecological cancer initiative, and we've firmly believe that by 2030, we can decrease, as I said, the incidence, the mortality, and the suffering from gynecological cancers by 50%. And we'll put that out there because it's achievable, and maybe we'll do better. Thank you.
Thank you very much, Diane. We do have perhaps time for a question or two, if there is a question from anybody in the audience or the panel. Or was there such clarity and eloquence in the presentation that it precludes the need for inquiry? Dorothy.
Thank you, Diane. That was great. I have a question for you, and it relates to Gina's presentation as well, in terms of where we might be going, given the way that today has been presented in terms of KT and looking at getting information out to the population. And then I take that back and say, okay, and to what extent can women actually have control of, input into their own care? And so we know that self-testing for HPV is likely to arrive, in terms, it already has, and Gina could wax eloquent about that. With respect to cervical cancer, I'm curious about whether the same technique has any application at all in terms of endometrial cancer.
I think that's an excellent question. And one of the things, the health determinants that increase the incidence of endometrial cancer also increase the incidence of a number of other major health problems. And one of the things we've discussed is very important for us to interface with women who are struggling with obesity, women who have cardiac disease, et cetera. And that's going to be a big challenge for us, because it's not simply doing a biomarker, well, sorry, David, simply doing a biomarker in the lab and making a discovery. It's really trying to develop those tools that allow women to make the decisions that will carry their health forward 20, 30 years from now. I think in many ways, and Gina can speak to this, the message for vaccination is probably a lot simpler than the message for endometrial cancer, because most of us, our thought horizon is a matter of a few years rather than what I'm going to be like 20 or 30 years from now. But I do think that we have that challenge, and the fact that it's going to be hard, I don't think that means we shouldn't take it upon ourselves to do it. One of the things that we did learn from our ovarian cancer knowledge translation is that women feel very empowered. I mean, a lot of the positive feedback we got on that initiative actually came from women who knew people who had had ovarian cancer. So it was very topical for them. I can't tell you how many calls I took from women saying, you know, have I had my fallopian tubes out? You know, like I'm psychic, I don't know. You know, because they'd had a hysterectomy and they asked, you know, is it likely that I've had my fallopian tubes out? And we just told them to search out their pathology report. But I think what I've found is that women do have the ability to be empowered. And I think if we can provide a meaningful and succinct and easy to use toolkit for preventing gynecological cancer, I actually am an optimist. In spite of working 25 years in cancer, I'm an optimist that we will be able to be successful at this project.
So thank you very much, Diane. I'd like to thank the three distinguished colleagues who've been speaking, and another thank you. And I believe Dr. Christelaw will now own the podium.
Give us one.